Chester Brodzinski is a 72-year-old male coming in with a complaint of shortness of breath. He says it started about 5 days ago. Nothing really seemed to provoke the onset. However, over the last few months, he has felt like it's been a bit more difficult to breathe while he's been doing things. But over the last couple days, he's been having shortness of breath all the time, including at rest. He has to use a couple pillows while he's sleeping, and that does seem to help. Otherwise, nothing is really improving his symptoms. He describes his shortness of breath as just feeling like he can't get enough air in, but he's not having any pain with it. Pertinent illnesses include a TIA back in 2009, high blood pressure diagnosed in his 40s, and type 2 diabetes diagnosed about 15 years ago. He's on metformin 500 milligrams, atorvastatin 20 milligrams, lisinopril 10 milligrams. His mother passed away at 73 years old from complications with a stroke. She had high blood pressure. His father died of a heart attack at the age of 68. He was overweight, was a smoker, and had COPD. He did smoke for about 20 to 25 years, but stopped smoking 20 years ago. Used to smoke 1 to 1.5 packs per day. Otherwise, no real pertinent social history. Review of symptoms include he has a loss of appetite, some weight gain due to swelling in his peripheries, and some fatigue, but no fever and chills. He is having erythema and brown pigmentation in the lower extremities. There's some skin tears and weeping on his legs. Otherwise, no other skin concerns at this time. No neuro concerns, no GI concerns, no sight concerns. He is having shortness of breath, but no pain. Some cardiac palpitations, and again, the lower extremity edema. Otherwise, no concerns there. Vitals are blood pressure of 137/85, heart rate of 103, temp 98.5, O2 92% on room air. Respirations are 24 beats per minute. I did a lung exam, and that showed respiratory effort that was mildly increased. There was no accessory muscle use. He had dullness to percussion in the base of both lungs, decreased excursion of the diaphragm, and then upon auscultation, there was coarse rhonchi and moist inspiratory crackles in the bilateral lower lung fields. Full cardiac exam showed auscultations. You could faintly hear the S1 and S2. 3 out of 6 holosystolic murmur was heard at the apex and radiated to the axilla, and his neck veins were distended bilaterally up to the mandible while the patient was sitting upright. Examination of his circulatory system and lower extremities showed bilateral lower extremity pitting edema with erythema. He had moderate desquamation and several ulcers, approximately 1 by 1 centimeter, on both extremities. Ulcers appeared to be in various stages of healing. Edema is 2+ in the lower extremities, and pulses on the dorsal pedis are faint, but they are palpable. No ascites. He is significantly obese, but no hepatosplenomegaly. An eye exam showed cotton wool spots and mild AV nicking bilaterally. An a monofilament test was done, and it showed no sensation in the plantar aspect of the foot. Labs were done. CBC was normal. A CMP showed an increased glucose as well as an increased creatinine at 1.48. BNP was significantly elevated at 829. A1C is 9.2%. EKG was abnormal. Chest x-ray showed consolidation fluid in the lungs. Lipid panel, all the triglycerides and LDL was elevated. HDL was 43. And then an echo showed a left ventricular ejection fraction of 26%, moderate left ventricular diastolic dysfunction, slightly reduced mitral inflow velocity, and a mild mitral regurg, less than 20% volume. So my initial thought on what we need to do with this patient is to admit him because he is decompensating due to heart failure and also not controlled on his diabetes. For the diabetes, I think it would be appropriate to add a basal and mealtime insulin. And then as far as his heart failure is concerned, I think it would be appropriate to add furosemide starting at 20 milligrams and then assess how he responds to that. And then I would also increase his lisinopril dose to a max of 40 milligrams. So we'll titrate up about 10 milligrams every 1 to 2 weeks. And then I would want a cardiac consultation about adding a beta blocker just because he does have a lot of edema. However, I would possibly want to add carvedilol 10 milligrams once daily for about 2 weeks and then titrate up as we go from there.